try to do this without a microphone. So for those of you in the back, if my voice is trailing, go like this. And if my voice is fine, go like this. I've been on call, so I'm a little bit fatigued. I've been in Richmond for more than 25 years. I've been a staff physician at ECU for the first part of my career. I've been a staff physician at McGuire VA for about 20 years, either full-time or part-time. I'm married in town. My wife is employed. We've been very happy in this community. But I just wanted to share with you, I'm not sure if you guys realize what a resource you have here and how unique this group is. So before we start, I just want to congratulate Russell and the board members for what they put together. This is a phenomenal group. I've been here every time I've been asked because I learn more from this group than I learn in any other meeting I go to. Because I hear what your concerns are, which is so much more important than some of the other things we deal with every day. What I've been asked to do is to talk about COPD. This is Russell's title, Cause, Effect, and What It Affects. Let's see if I can get this. Another way I look at it is what you really need to know about obstructive lung disease. I'm going to start with what I know. Then I'm going to go to what I want you to know. And then I'm going to talk about things we really don't know, but we really should know at this point. It's not a new disease, and yet we really don't know an awful lot about it. So let's think about some of the objectives. Let's review what the standard guidelines for COPD. Just what is COPD? Let's understand some of the changing paradigms. How are doctors looking at it now compared to 20 years ago and 30 years ago? And let's address some of the controversies in the management of COPD. This is called a faculty disclosure. This is actually requested of all academic faculty when we're presenting. You need to know I've done a lot of research over the last 20 years with a lot of different companies, a lot of different sponsors. What I'm suggesting is that this is not biasing the lecture. If anything, it's helped me learn more about some of the medications you're taking. And I'm here to tell you the truth, honestly. So, background. First of all, COPD is the third leading cause of death in the United States. Now, I'm not trying to scare those of you who have this disease, but I just want you to know what a healthcare impact it has in America. Over 12 million Americans are diagnosed with COPD, next slide please, and at least 12 million have not been diagnosed yet. They've been seen by their doctor with cough or with shortness of breath. They've been labeled as bronchitis or asthma. They have not been told that they have COPD. There's more than 140,000 deaths per year, that's an older slide, which really equates to about 1 death in America every 4 minutes. Now these are very old slides. You can see they've lost their color, they've lost their sound. But I like these slides because this is really based on some demographics from 1998 of leading causes of death in America. Now if you guys watch the news, you know that the leading cause of death in the United States is cardiovascular disease. More people die of heart disease than any other disease in America, followed by cancer. We've all had friends or family members afflicted with cancer. But now, moving up from number 4 to number 3, is respiratory diseases, predominantly COPD. Next slide. I use this slide because this is my life. This is my timeline. This is the change in age-adjusted deaths from 1965 to 1998. So admittedly, I came around before 1965. I can't lie. And I know it's not 1998, but these are the trends that I consider important in my daily practice. That if you look at heart disease and strokes and other peripheral vascular diseases and all other causes of death, in American healthcare systems, the mortality of these diseases has dropped over the past 30 years, but not with COPD. This is an increase in the rate of death from COPD in America from my childhood to the time I started my practice. That increase in mortality is seen not just in white American males, that you see it in African Americans, you see it in females. This is a universal disease. Now, how many of you, when you were young, always thought that emphysema was a man's disease? That's clearly not the case. Next slide. So what about women? We have a lot of women in this group. Some of you are supportive spouses. Some of you are afflicted with this disease. Next slide. Well, first of all, lung cancer is the leading cause of cancer death in women, more than breast cancer, uterine cancer, ovarian cancer combined. Next slide. Since 2001, more women die of COPD than men. So in my lifetime, in my professional career, it was predominantly a male disease. But right around 2001, for the first time in the history of American medical tracking, more women died of men. And that's been sustained throughout. Next slide. What do we attribute that to? There was a very aggressive campaign in the late 60s targeting women for smoking. Smoking was glamorous, it was chic. Movie actresses, princesses, politicians' wives, they all smoked. When the utilization of tobacco products in women increased from 1960 to 1980, the increase in COPD and lung cancer increased 10 and 20 years later. There's a lag time from our exposure to the time we're afflicted with the disease. So while cancer and COPD has kind of peaked in the male population, it's still on the upswing with women. So what is COPD? And I have my students go through this exercise every week. The things we think of when we hear about COPD is chronic bronchitis, emphysema, and asthma. Next one. But it actually includes a whole host of diseases that have in common obstruction of the airways. You have cystic fibrosis, bronchiectasis, bronchiolitis, something called alpha-1 antitrypsin deficiency, which is a genetic disorder that predisposes you to emphysema. What these all have in common is the inability to get air out because of airway obstruction. So one of the dilemmas with primary doctors in town, with some of my colleagues in the community, is that they treat COPD as if it's one disease. You come to the door and you say, I'm short of breath. You all go home with a handful of puffers, a couple of pills, and some oxygen, as if it's one problem. And each of those disorders that I showed you have nuances. They're very different from each other, and the treatment should be varied. So let's start with chronic bronchitis. This is defined as a clinical entity. It's defined as the presence of a productive cough with sputum for at least 3 months duration over a 2-year period. So it's not the cold that gives you a little bit of a cough. It's a chronic cough that persists over 2 years. It's a clinical diagnosis. Anatomically, you see thickening of the bronchial wall. You see excessive sputum production. It's very different than emphysema. It's very different than asthma. Next one. What about emphysema? Now, this is an anatomic description. It's really based on the fact that the working unit of the lungs, something called the alveoli, is destroyed. The alveoli is where air and blood vessels meet. It's at the very end of a bronchial tube. And that's the working unit of ventilation. It's where all the business of the lungs takes place. And over time, these units dilate and get destroyed, so they don't ventilate well and they don't perfuse well with blood vessels. So that's an anatomic definition. So here you have destruction of the alveolar unit. It tends in smokers to be apical predominant, which means the upper portion of the lung is more afflicted than the base. There are some disorders that affect the base of the lung more than the top. I heard a few people mention that they had asbestos. Asbestos fibers from their inhale affect the base of the lungs. Tobacco, pollution, other things that give you emphysema tend to affect the upper portion of the lung. And then as it advances, can involve the entire lung. This is actually an anatomic specimen of the lung. You can see how the top of the lung is destroyed compared to the bases of the lung. That's what we see when we're looking at the patient. Next slide, please. So here we have 5 or 6 different diseases that all can give you obstruction of the bronchial tube. So what causes that? What do they have in common? Well, what I teach my students is that all of the diseases we see in the lung are kind of the balance between the host, that's you, and your genetics, and how you're built, the environment, things around us, and how they interact. So there are some host diseases, environmental diseases, and then some things that are unfortunate, like infections. All that can trigger lung disease leads to either abnormal tissue injury or normal injury with abnormal tissue repair. For those of you with fibrosis of the lung, that's really a disease where the repair of the lung is impaired. You're scarring instead of healing. So there are diseases where it's either injury or abnormal repair, and that ultimately leads you to the disorders we're talking about. Next slide. So host factors are things like children who were asthmatics are more susceptible to chronic lung disease as adults. So whatever allergies and whatever issues they had growing up predisposes them at a later time in life for emphysema or COPD. You could be born with protease deficiencies. That's what alpha-1 antitrypsin deficiency is. I don't know if anyone in the room has that diagnosis. Or
We've had that tested on 3-year intervals. We have somebody come in during flu shot season in October, and we've had, I think, 3 people out of 100 people.
It's fairly uncommon.
Right.
It's more common when someone presents with emphysema at an unusual age, in their 30s rather than in their 50s. But we do see it when we screen for it. And then there are other genetic disorders that predispose to lung disease. So those are your innate host factors. Those are your genes. We can't do much about that. Then we have environmental factors and infectious factors. Next slide, please. Infections can be typical infections, but the things that affect the lungs really adversely are certain viruses, atypical infections like tuberculosis strains, or someone said they were just treated for MAC, which is a tuberculosis strain. These could be very destructive in the lungs. And then TB itself, we grew up in the TB era. I saw a lot of TB when I was in school. We don't see as much now, but clearly in the 60s and 70s and 80s, we have a lot of tuberculosis. And in terms of the environment, we know about tobacco and what it can do. But there are other things, occupational dust, gases, pollution, they all affect the lungs. I came out here from California originally and then New York. When I came to Virginia for the first time in my career, I was taking care of dust-related illnesses. The western part of the state in the cold. I was taking care of more asbestos than I had ever seen in my life due to the Newport News shipyard. So I had to really learn about this population geographically and the diseases they have compared to sunny Southern California. All of these things, when you put them together, lead to tissue injury repair and ultimately, next slide, the diagnosis of COPD. So now you have an idea of the different roads that lead to it. I tell my students, it's kind of like saying we're going from Richmond to DC. There are lots of different ways you can get there, but eventually you end up at DC.